everyone. This is Leora from Wednesday Wellness Podcast, and today we're continuing our series of 10 episodes about breast implant illness, explant, surgery, recovery, and healing. And we're going to talk today about processing of the capsules during explant surgery, and we'll look into what it means screening for pathogens of those capsules. And we have with us tonight Dr. Randall Feingold. He is co-founder of New York Breast Reconstruction and Aesthetic Plastic Surgery. He's also a pioneer in bloc explant surgery, breast reconstruction, restoring of the breast, as well as aesthetic procedures. So thank you, Dr. Randall Feingold, for being here with us tonight. And the first thing is can you take us through, almost take us with you to the surgery room and tell us what happens once you're physically removing the breast implants, and what are you looking for and what is the next step?
Well, thanks for having me today, Leora, to discuss this topic. And I just want to point out to the audience that we previously discussed both technique for explanting patients, but also techniques for restoring breast aesthetics after explantation, because we want women to be comfortable with their body and feel self-confidence and self-esteem after going through these surgeries. But part of it is about restoring health, and many of my patients have symptoms. And so in order to help patients feel better after surgery, we have to do our best to identify potential sources of symptoms. And we have to be sort of medical detectives and not forget that this is an important part of the operation. So when I go to the operating room and I remove a capsule in totality, this begins with a visual inspection of the capsule. Is it a very thin capsule, almost paper thin that you can see through? Is it a very thick capsule that appears inflamed? Are there any masses on the surface of the capsule? Or eventually, when we open it on the inside of the capsule, are there calcifications? Many times I find silicone gel bleed inside the capsule, even though the implant is intact, because we know that some implants will have passage of silicone gel through the envelope of the implant, even though it appears to be intact. And then, of course, we look for outright rupture or disintegration of the implant, which is often detectable simply by looking at the capsule from the outside and feeling it with your fingers, and you can tell that something's gone wrong on the inside. So part of my evaluation begins just by inspection during the course of capsule removal.
Okay, so this is really interesting. Can you tell us, is this a factor of time that those implants are getting moldy, or is it something else?
Well, I don't have enough education in material science to understand why silicone implants break down over years, because I have patients that come in with a perfectly intact implant on one side and a fully disintegrated or ruptured implant on the other side, and yet they were placed on the same day by the same surgeon in one operation. And so we just don't understand the lifespan of implants, or why some implants will break down and why some patients will have totally different outcomes in each breast. But when we look at the capsules, we can't even tell from the appearance of the capsule if this is something that's causing symptoms in the patient, because I have patients with many symptoms that have innocent-looking thin capsules, and patients with few symptoms that have very affected capsules that look terrible on the outside and the inside, and yet they don't have symptoms. So we have to look beyond the appearance of the capsule or even the appearance of the implant to understand what's happening with our patients. And that's why factors like studying pathology and microbiology are very important. I had one patient that had a mass in the lining of the capsule, and that turned out to be a malignancy. But I had two other patients that had malignancies of their capsules, and the lining appeared completely normal to the naked eye.
Wow.
And so that capsule will be sent in totality to the hospital pathology department. And then they're going to study it to see if it's benign tissue, if there's inflammation, whether it's chronic or severe, if there's foreign bodies in the capsule, such as silicone or calcifications, or rarely a malignancy. But then I will take biopsy specimens from the internal lining of the capsule and send that to the microbiology laboratory. And they will look at that for both bacteria and fungal cultures.
Interesting. So I understand that over the years, you've done thousands of this surgery. You have developed a protocol.
Yes. I never deviate from it. And it goes to the concept of you never know what you're going to find if you don't look for it. And we don't want to throw away the evidence. And when I started doing capsulectomies for explant patients and sending it for both pathology and bacterial and fungal evaluation, at first I thought I'm never going to find anything here. But then I was surprised to see that 25-30% of my patients have positive cultures. And there are many different bacteria and even some fungus that I've identified with consistency in many patients. The most common being Propionibacterium, which they renamed Cutibacterium. That's an organism that causes highly inflammatory acne if you found it in the skin, and it certainly has no business being in your breast for years or decades. But I've also found Staphylococcus, MRSA, which is methicillin-resistant Staphylococcus, Streptococcus. I've found bacteria that are more commonly identified with coming from human saliva or even vaginal flora. It makes no sense why these bacteria would be in there, but I have a suspicion that it's not good for any human being and that it's not a big leap of faith that some of these organisms are secreting inflammatory enzymes or other chemicals that are interfering with normal health and physiology. I've even had a couple of patients with unusual fungus in their capsules. I'm not talking about mold inside a saline implant. I'm talking about colonies of fungus inside their capsules. And so my protocol is to send it for these evaluations. It takes 5 days for bacterial identification. It takes 28 days for fungal identification.
Yeah.
But if somebody has a positive culture, then we're going to have another conversation about should we treat a patient? Because an infectious disease expert might say, well, the implant is out, the capsule's out. Maybe you're just fine. But we really don't know whether or not these organisms permeate through the capsule and are still embedded within the breast tissue. How sterile should we make the breast? Because all breasts have some bacteria in them that may come in through the nipple. That's not a total surprise. But patients who have symptoms, who have organisms in their capsules, I will generally treat them for 4 weeks of antibiotics if they have positive bacterial cultures and a couple of weeks with antifungals if they have positive fungal cultures.
Are there right now any guidelines for plastic surgery and for pathology screening?
Well, just as with the bacterial and fungal cultures, we're making decisions about screening for these entities because we think it may be of benefit to our patient. I don't see any value in discarding this tissue. And the pathologists, they know best how to screen the capsules for pathology. They will typically report back that capsules are just benign fibrous tissue. They will often report on the degree of inflammation, which is of no surprise in the presence of foreign bodies. When it comes to malignancies, the thing that most patients have heard about is breast implant associated ALCL or anaplastic large cell lymphoma. That's associated with biocell textured implants that are no longer available in the marketplace. But these are the cancers that have really gone to public attention.
Yeah.
So if the pathologists identify a population of large T cells, then they would go on and do staining, immunohistochemical staining for markers such as CD30 or ALK to determine if it is in the subclassification of ALCL, which is a very curable, treatable disease with total capsulectomy, but apparently it's caused by implant surfaces themselves. And that's why I think textured surfaces, textured implant capsules should be removed. But there are other cancers that are identified by the pathologist. So I know they're very diligent. Whatever their protocols are for studying it must be very thorough, because I've had one breast implant associated squamous cell carcinoma identified, which has now been reported in just under 20 cases in the United States. Unfortunately, it's a very aggressive disease that most patients, unfortunately, will die from in short time periods. And then I've had pathologists surprise me with identification of B-cell lymphoma in one woman's capsule that was completely unexpected, with smooth implant surfaces, and another patient in which both implant capsules were riddled with a T-cell lymphoma, which was not breast implant associated ALCL. It was a different kind of a T-cell lymphoma that she now has a systemic disease from, and she's being monitored by her oncologist. So we have to trust our pathologists that they know how to look at the capsules and give us feedback. And as rare as these cancers are, there have been increasing numbers of reports from the FDA and the American Society of Plastic Surgeons about these other previously unreported or unrecognized cancers in breast implant capsules.
So I assume that the percentage has gone up.
The mathematical modeling is that the risk may be 1 in 100 at 20 years. So that's why the biocell textured implants really should be removed, and why I believe we're serving patients better by removing the capsules before they get cancer rather than waiting for them to get cancer, even though it's treatable. The squamous cells and the other B-cell and T-cell lymphomas are truly rare in terms of the numbers reported, but I suspect now that there's more awareness of this, there will be more plastic surgeons sending capsules to pathology. There will be more unrecognized cancers, even if they're low-grade and curable, discovered in those capsules. And so the true numbers are not fully understood yet, and it may take years of more capsule specimen analysis and better reporting by plastic surgeons to authorities that can collate this data to come up with the true incidence. So I think they're rare, but they're not zero. This just goes to the reasonableness of removing breast implant capsules at the time of breast implant removal.
Do you see any correlation between the edge of the implants and how inflamed are they in pathology?
I'm not sure that I see an age dependency there. They talk about breast implants, for example, leaking after a certain number of years and what their shelf life or lifespan may be. But I've seen implants leak as early as 3 years after implantation, and other implants that seem to be perfectly intact after 20 years. So I don't have a good guideline to tell patients if they have an existing implant about when's the right time to, say, change an implant in a proactive way to not have to deal with a leaking implant, because it's a little bit haphazard when these occur. And the patients that come to me with systemic symptoms of breast implant illness will report symptoms as soon as the first year of having implants in their body. And some people developing symptoms 7 to 10 years after implants in their body. So this is an area where study and analysis has to occur to a greater degree before we can confidently predict who's at risk and what the time frame might be and when to intercede.
Well, I had a question here from one of our previous listeners regarding the pathology test, and she was asking if there is any currently test to find silicon and heavy metals. That can you actually diagnose this?
Well, there are laboratories that can study tissues and fluids from anyone's body for the presence of heavy metals. I don't know that I can send capsules from my operating room to the hospital and reliably get heavy metal analysis without first setting up a research protocol and get approval from an institutional review board, just because of the costs of those types of studies and the amount of time that will need to be dedicated to study those tissues to get analysis. So it will be probably difficult for the average citizen to say, when you send my capsule out, make sure you study for platinum and lead and any arsenic and any other types of elements or metals that could be in it. So those kind of studies have been done and they're in progress, and there is some very rudimentary data out there in small samples about the presence of heavy metals, for example, in the tissues of people who have breast implants. But we just don't know yet the exact significance of it or even how to treat it.
Yeah. I've been spending time on Facebook groups where I guess there are about hundreds of thousands of women there. And there is a lot of information. The general consensus is that what caused the illness is silicone bleeding into the body. And it seems like there is less attention to the bacteria, biofilm, and the pathogens that are actually around the capsule. And you mentioned the P. acne. That bacteria actually is exactly what women are describing as breast implant illness. For example, that bacteria sit in the skin, in the brain, bones, inflame the joint, the GI tract, the oral cavities, even the external ears, and cause inflammation and conditions like brain fog. And by the way, it sits in the hair follicles and create inflammation. There are quite almost 20 symptoms that could be related to breast implant illness just from that specific bacteria.
I think you're bringing up an important point. People who have symptoms may have different reasons for their symptoms in different patients. It could be a reaction to a foreign object in the body. And don't forget, some silicone shelled implants are filled with saline. They don't even have silicone gel. And yet patients with saline implants can have symptoms just like patients with silicone gel implants. So it could be a reaction to having a foreign body. It could be a reaction to the silicone elastomer shell, which is a harder rubber and not the actual silicone gel and the silicone gel implants that doesn't even exist in the saline implant. It could be biofilm. It could be more established colonies of bacteria or fungus in the capsule. It could have something to do with genetics and certain genetic mutations that some patients have that may make them more susceptible to having immune reactions to silicone elastomer or silicone gel. There may be more than one reason why people have symptoms. And that's why I think to do our best job for our patients, as I said, we have to be medical detectives, not rule out such possibilities, remove capsule tissue, study it for potential pathology, bacteriology, mycology, which is fungus, and have an open mind as to why people might have symptoms and how we might make them better. Because many patients do feel better after these surgeries.
Yes, I actually looked at one study that says that 96% of women that were studied between the years of 2016 to 20, they actually reported that they were feeling much better. And out of this, I think there were 2,000 women that were examined. Actually, 50% had that bacteria, the P. acne. And that explains also a lot of their breast implant illness symptoms.
Well, that is the most dominant bacteria in the cultures that I obtained, in addition to all the other types of organisms that I've seen that I've mentioned. But yet we have patients that have negative cultures and they have a lot of symptoms. And they were kind of hoping to hear that the bacteria or fungus culture would be positive.
Yes.
Kind of a specific thing that you could hang your hat on and say, see, this is where my symptoms were coming from.
Yes.
They also have to do with the body's response, as I said, to silicone shell or silicone gel. And so we have to have an open mind and be grateful that patients feel better after surgery. We just may not always have an exact answer as to their cause. I wish 96% of my patients felt, better or cured after surgery. It is a significantly high percentage of patients that do feel better, but it does take time. Some patients report tremendous relief within a month. Other patients are feeling partial improvements that accrue over a year. And I try to remind patients that their exposure to the silicone shell or the gel or to the chronic bacteria or fungus in their body might have been a 20-year exposure process.
Yeah.
And triggering of responses by the body, whether it's an autoimmune response, an endocrine response, a neuro response, a humoral response, what have you. And that just because you took away that inciting agent doesn't mean the body winds down immediately. Chronic activation or inflammation or immune, hyperactivity. So people do have to be patient and have an optimistic outlook on this.
So I do want to speak about this small percentage that actually, just like myself, so their culture came negative, my culture came negative. I was very happy. Initially, I was feeling much better. And then I started getting inflammation in the hair follicles and joint pain. Do you think that it's possible to actually have those biofilm in your system and not have it detected during the surgery?
Well, I think that our laboratory's ability to detect the bacteria, the fungus, or these malignancies is very, very high sensitivity. It doesn't mean that someone doesn't have residual bacteria or fungus in their breast tissue. Maybe there's the possibility that once you have certain disease state that's activated by this, that people can have chronic illness from it, and that it's not always cured by explant or capsulectomy. Maybe they have some low-grade or residual symptoms that come and go, and there are the other factors in their body that make them susceptible to symptom reactivation. This is an area that's not gotten a lot of attention in the, scientific community or the laboratories of the world, except for the fact of decades and decades of reporting of symptomatic patients and uncertainty as to how to connect it to, their implants or even their capsules. So I think we have to have an open mind and more research needs to be done, but I still have to treat real people that come in every day that have symptoms and have concerns. And so I'm just trying to adopt a protocol that's safe for the patient, that's making them comfortable with their breasts after surgery through restorative methods that are done simultaneous with the capsulectomy, and still being a good doctor by studying the specimens that come out, so that patients who have bacteria or fungus can consider taking some additional therapy, particularly if they had symptoms.
Yeah.
The people that have unsuspected cancers can understand what their risks are and whether they need treatment or not afterwards. So this is still compatible with, conventional medical wisdom. We have to give every patient credibility when they come with these symptoms and be good medical detectives.
Just one last point, and I think you just already mentioned it a few seconds ago about treating the 50% of women that are coming back with positive culture pathogens. And other than antibiotics or that are sometimes prescribed, I think that nutritional guidelines, especially when there is candida and the P. acne, are really important to healing these symptoms, limiting overgrowth of bacteria in the body. We're going to dedicate another episode to healing inflammation that is caused by biofilm and candida and other pathogens. We have to look into the nutrition, the lifestyle, the stress, the environment. Even 5G exposure can make things worse for a lot of us. I think that you, Dr. Feingold, mentioned it a few times that women needs to rule out other condition and to look into, not blame everything on breast implant, because there are so many high expectations that once the breast implants are removed, everything will be fine, back to normal.
That is an important point. And as I probably mentioned in a previous podcast, we want patients to undergo general medical workups and not come in exclusively blaming their breast implant on their symptoms, because we wouldn't want to overlook some other condition. So if they've been to a rheumatologist, an infectious disease doctor, an endocrinologist, even a family doctor who can study their blood chemistries in a variety of areas to at least make sure they don't have a very treatable condition that's responsible for their symptoms, that's good medicine. That should always be going on. But having said that, I'm not sure that traditional medicine has all the answers when it comes to understanding who might be at risk from these symptoms or illnesses from their breast implants. Is there a genetic basis for some patients? Is there a nutritional basis for some patients? Is there environmental causes or risk factors that we're all exposed to that some of us may be more vulnerable to that could trigger these types of symptoms in patients? I'm sure it's multifactorial. Time to have better clarity on it, but we still have to treat every day real patients coming in that have symptoms who are looking for answers. So we just have to do it in a safe and responsible manner.
One last subject before we end up this episode is about screening after explant surgery and the importance of a mammogram and ultrasound.
So every woman who comes in with a breast implant is still a woman with a breast that has the same susceptibilities or vulnerabilities or risk factors for conditions such as breast cancer as women who don't have breast implants. And so if patients come in and they're overdue for breast imaging, I may suggest that or recommend that as a prerequisite to having their surgery. In fact, the woman that I discovered T-cell lymphomas in her breast capsules came to me specifically for breast implant illness systemic symptoms. I examined her and saw that she had some enlarged lymph nodes. She had not had recent breast imaging. I sent her for breast imaging. Breast imaging identified a mass in her breast that turned out to be a breast cancer on a needle biopsy. So now she needed to have mastectomy surgery, which was not part of her original plan, obviously. Yeah. But they also needle biopsied one of the enlarged lymph nodes that I had felt in her armpit. And we thought it was going to come back as metastatic breast cancer, but it actually came back as T-cell lymphoma, totally unrelated to her breast cancer. I ended up doing bloc explants, but on the day of her mastectomies, not in my office operatory as she originally intended. And those capsules turned out to be the ones that were filled with T-cell lymphoma, not with breast cancer. So breast imaging can change the direction of someone's treatment. It's very important. And after they're done with capsulectomy explant and they're healed, and hopefully their symptoms are improved or even resolved, they still have to do normal health maintenance and normal health surveillance. And that means taking care of your breasts, whether it's through nutrition or proper hormone balance, and getting surveillance of the breast through imaging studies as recommended based upon your age and your family history and other known genetic risk factors.
So I just want to say, because we're talking about mammogram and ultrasound, that I've done explant and fat transfer with you almost 2 years ago. And I just recently had my mammogram. And obviously I was really, really nervous because I haven't done any of those imaging screening for like almost 2 years, even more. And my mammogram and ultrasound came up so clear. I had no cyst and no oil cyst, no lumps. And because, as you know, in the Facebook group, there is so much misinformation about fat transfer, and everybody thinks that it's going to be an obstacle into reading those imaging, which was not in my case, as you promised me, by the way. So I was so excited, and I posted it on Instagram and on Facebook, and it was such an amazing relief to know that I did the right thing, and everything is good. So I just wanted to share it with our listeners.
I'm grateful that you got your imaging, which you're supposed to do at proper intervals for your age. To hear that breasts are clear and benign and there's no evidence, that's great. I'm not surprised to hear that there is clear breast tissue and body fat without fat necrosis and oil cysts and other nodules in the breast from fat grafting, because we really don't find that very commonly. And many years ago, the radiologists that were first beginning to read imaging in women that had fat transfers to the breast had to go up that learning curve of what should this look like? What does it look like? But now, at least in areas that I practice in, where there's a high volume of breast screening and the radiologists are well experienced and educated, there's no confusion. Fat transfer to the breast does not cause breast cancer, nor does it inhibit normal screening from detecting breast cancer, nor does it mimic breast cancer. So I think at this point, the science and the experience is solid, and some of the conversations in social media about it are probably because they just don't have access to the data or the experience from those of us that do high volumes of fat transfer in our practice. But it's now standard of care in the United States and around the world that fat grafting is a really important element in both reconstructive and aesthetic surgery.
Yes. So I just want to thank you, Dr. Randall Feingold, for sharing with us this important information. As always, it has been a pleasure. And I want to tell our subscribers that if you want to get direct notifications, just subscribe below, and we'll see you in our next episode. Thank you, Dr. Randall Feingold.
Thank you, Lior. A pleasure to be here. Thank you.
Take care. Bye-bye.